Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening. Welcome to Dialogue with a Doctor. We're here this evening with Dr. Raymond Phillips. He's a practicing gastroenterologist in Naples, Florida. And this is my co-host, Jim York. And
Dr. Phillips, welcome coming back to our show again.
Thank you for having me again.
If you could just again maybe go over your background and where your practice is located.
Sure. Well, I'm a gastroenterologist, and I practice with Dr. Lebersky, Dr. Randall, Dr. Marks, and Dr. Khatib, and our practice is on Goodlet Road. I'm a gastroenterologist, but what does that mean? We're specialists in gastrointestinal illnesses as well as liver diseases, and in order to achieve that, there's a number of years of training. I went to college at Princeton, went to medical school at Washington University in St. Louis, and then after that, I did my internal medicine training at Jefferson Hospital in Philadelphia, and I was chief resident after 3 years. I'd gone through college on an ROTC scholarship, so at that point, I was brought on active duty as an internist and assigned to Fort Leonard Wood, Missouri for 2 years. Then after that, I did my gastroenterology training at Walter Reed and was there for 2 years doing my training. And then I was on staff at Walter Reed from 1989 to 1991. And then after that, I retired from the military and came down here to Naples for the last 20 years and been practicing with the other doctors, as I said.
And your offices are located where?
Yeah, our main office is on Goodlet Road, and we have offices in Bonita, on Bonita Beach Road, as well as on Marco Island.
I guess we're here tonight to talk about prostate cancer.
Well, prostate cancer is pretty interesting, but I'm really interested in colon cancer.
I mean, colon cancer, I'm sorry.
same kind
Same
of location.
correlation.
What it is. But tell us about colon cancer. Give us some history there.
Well, let me give you a little background so you understand the medical impact of colon cancer in the United States. It's the second leading cause of cancer death in the United States. There's 50,000 deaths per year, about 140,000 new cases per year. It affects women and men equally, equal opportunity offender. And as far as the level of it has diminished to a degree in the last 15 years, but it remains a real public health issue across the United States. Now, in terms of our understanding of it, it's undergone a terrific evolution over the last 30 years. It really became, a number of celebrities over the years have had colon cancer, all the way from, Vince Lombardi to Audrey Hepburn. But as in 1984, when President Reagan was discovered with colon cancer, it really became sort of in the public eye of something to be, something to be aware of. And with the discovery of his colon cancer with a technique called a colonoscopy then became a sort of the premier tool that we had available for not only for detecting colon cancer. It was about that same time frame in the early 1990s that we had a more fundamental understanding of the nature of colon cancer, to the extent that it wasn't something that just sprung up overnight. It actually was a condition that evolved slowly over years and years, initially developing from something called a polyp. I ought to digress. What a polyp is it's not normal tissue, it's not cancerous tissue. It's just tissue that's growing faster than the surrounding tissue. And because of that characteristic, as it grows and as it evolves, it tends to accumulate in one spot. And as it accumulates, it develops an appearance that looks a lot like a mushroom. A little stalk to it, a little head to it. Real slow process. It takes 5-7 years for that to occur. But during that time, on occasion, a little cancer cell can form within the polyp, and that can mature over another couple of years to form a full-blown cancer. So it can be a long, drawn-out process, anywhere from 5 to 10 years in length. But if you were to discover a polyp and remove it, you could prevent it from ever maturing into a cancer.
So any polyp could become cancerous, you're saying?
That in general is true. Now, to every rule there is an exception. There are occasional polyp that are just like bumps on the landscape. They're not anything serious, and they'll never amount to anything substantial. But the majority of polyps, have that precancerous capability. And it was with this understanding that I've just described to you that it formed the foundation for trying to identify polyps, and by identifying polyps and removing them, the notion had been that we could potentially prevent colon cancer. And it was in the early 1990s, a large clinical trial was concluded that actually demonstrated that you could actually reduce the incidence of colon cancer by doing systematic screening colonoscopy, and in those individuals who had polyps, to periodically come back and re-examine them to look for any new developing polyps. So that strategy, about 20 years ago that it was implemented, but now widely embraced, and indeed insurance companies to a large extent now have embraced it. And you know when they embrace something, when they pay for something, is that they've embraced the notion of preventative medicine in this context, because now we can actually identify a polyp, remove it, and prevent a potential colon cancer from occurring. Now, this is a real slow process, so as a result, there's no need to come out real frequently to have this done. And as it turns out, around the age of 50, 55, 60, that's when polyps begin to be more common in the general population. And so that's why we encourage people when they get into that age group to have a screening colonoscopy done. Now, because we understand the physiology better and know how slowly this process evolves, if an individual has a polyp removed, we used to believe, oh, gee, they should come back in a year, because a year seemed like a long time. But when we finally did the studies and showed how slowly this process evolved, we found that a 5-year interval was perfectly satisfactory for coming back and identifying any new polyps. And that in those individuals who had no polyps or had no significant family history, a 10-year interval was a very safe interval as far as preventing something serious. So it was on that basis that the thought had been that we could prevent potentially up to about 90% of all colon cancer in the United States if we could encourage everybody to have a screening examination, that should have a screening examination. Now, I keep talking about colonoscopy. Of course, there are other methods that have been used to screen for cancer, to detect cancer. And the one that had gotten the most attention over the years is this test called stool guaiac, or Hemoccult testing. And there's other names for it. But the notion in all of them was the same, was to detect cancer, the presence of hidden blood, occult blood in the stool, with the notion being that if that was present, it is likely as a consequence of bleeding from a small cancer or cancer developing within the colon. And just as another digression, a little vignette, as I mentioned earlier, President Reagan had colon cancer detected during his presidency. And presidents are busy people. They go here and they go there, and in terms of doing a physical with him, not an easy thing to do. And on his physical, occult blood was detected on a stool guaiac. And they didn't believe it, so they repeated it, and that wasn't an easy thing to do, because you have to be off of meat for a time, and he's busy going here and there, and they repeated it again the second time, and it was positive again. They repeated it again. Well, that can't be possible. It must be a mistake. And he'd say, well, I ate a steak last night with that big dinner and everything. So then they did it a third time, and it was positive. And then just because they still didn't believe it, they did a fourth and a fifth and a sixth time. Well, this took 18 months to accumulate all this information. And by the sixth one that was positive, they realized, we got something serious. We got to evaluate here. And they finally did do a colonoscopy and detected a cancer. And that was successfully removed through an op. Didn't require any adjuvant therapy in terms of chemotherapy, and he was cured. But it wasn't because of timely intervention. and fortunately, at the time, he was being cared for by my naval colleagues. I was in the Army, and the naval gastroenterologists came under withering criticism from the gastroenterology community in the United States because of the extreme delay in terms of his evaluation. And it was subsequently very clear that any abnormal presence of blood deserves immediate attention and evaluation. And it's not the best 2 out of 3 or 3 out of 5 or 4 out of 7. It's like the presence of any blood deserves immediate evaluation. And it didn't really necessarily occur in this circumstance. So, but anyway, things worked out well in the end, and sometimes it is better to be lucky than good. And so so that was the impetus and for these trials in the late 80s and 90s, looking for a means of prevention. And that's how things have changed at this point, gone from early detection of cancer to prevention. Now, of course, there's other techniques besides the presence of hidden blood that's been, and there's been refinements of that, a more detailed testing of the presence of blood that's unique to humans using a special kind of immune-mediated test. Won't get into that, but it's interesting. There's now even very sophisticated tests where you can actually check DNA within the stool to look for abnormal DNA that might be shed from developing cancer cells within the colon. And that has been very exciting, but it's not really available on a widespread basis and is not reliable enough to really be used. As it turns out, again and again, the direct evaluation in some fashion has been useful, although virtual colonoscopy, where the imaging technique of the abdomen and reconstructing through two-dimensional images of the abdomen achieved through a CAT scan, and reconstructing those two-dimensional images into a three-dimensional picture of the colon, and then doing a little bit more computer enhancement, you can get the perspective as if you're flying to the colon and you can actually do an examination of the colon without literally having to be inside of it or have some kind of instrument inside of you. And that has been very exciting, virtual colonoscopy, and has a role and those and certain individuals in certain circumstances, or individuals frankly just don't want to take the time off and to be sedated, take a day off to have a colonoscopy. The limitation of it is that it's purely a detection tool, and it can detect polyps that is extremely small, but because of its capability as far as detection and its ability to detect things at a very, very small level, it's detecting many, many polyps that are then leading to having to have another preparation for a direct examination of colonoscopy. So it's a little bit of a challenge for patients because, you know, the actual colonoscopy itself is not a difficult examination for the patient. In fact, it's a fairly easy one to do. It's just the preparation is the challenge. And most people just don't like to undergo two preparations in any kind of short time frame. And that's what I was mentioning with the virtual colonoscopy is you have to have a preparation for that. And if you identify an abnormality, then you have to have another preparation for a colonoscopy. So many people have not opted for that approach. And frankly, there's insurance issues right now. It's not altogether clear whether insurance will pay for it. And that's another sort of hindrance in terms of its widespread use at this point.
Is there any other symptoms for colon cancer besides the blood in your stool, or not? Or?
Yeah, and there are other symptoms, you know, and we've asked patients to be always on the alert for the presence of obvious blood, a change in bowel habits, to the extent of less frequent movements or more frequent movements, change in the appearance of stool, a thin caliper stool, or changing appearance over time, abdominal discomfort that's not going away. Essentially any new abdominal symptom or change in bowel habits, we encourage people to let us know about this. And you might say, well, Dr. Phillips, if you've had a colonoscopy, why should you pay any attention to that at all? It was, well, you know, I said earlier, we believe we could prevent up to 90% of all colon cancer by doing a colonoscopy. I didn't say 100%, and we'll get into the details of why it's not 100% in just a bit, but one of them is that sometimes colon cancers can be precocious. They can be fast growing, that instead of taking years and years and years to evolve into something serious, sometimes it can happen over a fairly rapid process, over 2 or 3 or 4 years. That's a rare thing, fortunately, and so 98% of all colon cancers don't have that kind of property. They're rather slow growing, but a small percentage can be rapidly growing. And that's why we always caution people, hey, if you have new symptoms, you still got to let us know about things and not ignore them.
We're going to take a short break, and we're going to come back with Dr. Phillips after this break and talk more about colon cancer and colon prevention more than anything else, colon cancer prevention.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
The survival rate from early caught breast cancer is about 97%. Mammography saves lives by detecting that breast cancer early.
Radiology Regional Center, earning your trust yesterday, today, and tomorrow.
Radiology Regional Center is happy to bring you digital mammography. The advantages include shorter exam time, fewer retakes, and lower dose radiation. Radiology Regional Center, the best just got better.
Welcome back to Dialogue with the Doctor. We're here this evening with Dr. Phillips, a practicing gastroenterologist in Naples, Florida. And we're talking, and I'm also with my co-host Jim York. We're talking about colon cancer prevention. And before we get on to what you were just going to talk about, many of my patients asked about the frequency of the colonoscopy. You were saying 5 years, 10 years. At one point there was some, could you clear that up a little bit? If you get, go ahead, I'm sorry.
Well, the general recommendation for the frequency of a colonoscopy is that if you're an individual that has no significant family history and you have a colonoscopy and there's no sign of any polyps, and you've done a good examination, if the gastroenterologist has done a good examination, a thorough one, then and the preparation is good, then a 10-year interval is a very satisfactory interval, is a very safe interval. Indeed, studies have been done showing that there's a protection from a colonoscopy that can last up to 15 years. If a polyp is identified, and it's not a particularly large polyp, and there's not numerous polyps, then an interval about 5 years to follow up would be reasonable. And the notion here is if you've identified polyps and removed them, that individual clearly then has a tendency to form polyps, and you'd want to come back in a shorter time frame than a 10-year interval.
At one point I can recall patients being tested. If they had a polyp, then they would repeat in a year, and if they were clear, then they would go for longer. That's not being done now?
Well, a year seems like a long time. And when we first began doing colonoscopy, because a year seemed like a long duration of time, we'd have people come back in a year's time. But when we did the detailed studies that showed how slowly polyps accumulate, it became apparent that, hey, gee, it wasn't necessary to come back in a year or two, that a longer interval would be perfectly satisfactory. Now, so that's why we have this interval of 5 years. Now, there's always exceptions to that. If a person has a particularly large polyp, then it's often reasonable to come back in a year's time or in 3 years' time, depending on the circumstance. If there's a question about the preparation, hey, it's not clear that everything was closely examined, it would be prudent to come back in a shorter time frame, less than a year's time. So there's exceptions to that rule. But in general now, with the caveats that I just mentioned, that, hey, if you do a good examination and you've had a good preparation and there's no significant family history and there's no polyps, yeah, 10-year interval is a very safe interval to go. And a shorter interval, 5 years, if polyps are identified and confidently removed.
And you said it's not 100% preventable because some cancers grow more quickly. Is that the reason for that?
And there's two reasons why this examination is not 100%. And one, as you mentioned, that is to say there are some polyps that are precocious. They grow more rapidly, and they go more rapidly than normal. You know, instead of taking years and years and years, they grow up and evolve within a 1 or 2 or 3 years, and typically a 2 to 3 interval. And those are fairly rare, fortunately, which is good. The other issue, and that has received a great deal of attention now in our community, is the issue of the thoroughness of the examination. Now, the thoroughness of the examination revolves around 2 points, because there's 2 people involved, the patient as well as the doctor. It is the doctor doing a thorough examination, but also the patient who does the preparation, making and investing an effort to really do a thorough preparation so they're completely cleared out. And that involves taking these various laxatives, and there's a variety of them available, and I won't go through the different names of them, but the point is they're all designed to have a laxative effect to allow you to clear out your colon completely. And it's really important for an individual to invest time and effort to do a good job there. Because if there's a lot of retained material, it's very difficult for the gastroenterologist to do an accurate and complete examination. So that's the area in terms of preparation as well as inspection. On the inspection side, we always try to improve things by having the best instruments, having improved imaging. The imaging has improved a great deal over the last several years. Invest time and not rushing through examinations. And that's why, not only for patient comfort, but to allow us to be confident that we're not going to create discomfort and thereby rush through an examination. Often sedation makes a big difference for us to be able to concentrate on the examination and not fret about the individual having a lot of discomfort and trying to do an examination rapidly to minimize discomfort. So it is a joint effort to do an excellent job, and it's worthwhile for the preparation to be really reviewed closely before you actually undertake it.
So what other things can be done to prevent colon cancer? Well,
to this point, we've talked almost exclusively about, hey, the doctor doing this test or that test, and a lot of people ask me, well, what can I do as an individual? Is there something I should do in terms of eating or particular foods to avoid or medicines I could take? And that's been looked at intensively over these last 25 years, looking at various things called micronutrients that are present in the food, like folate or B vitamins or beta carotene or selenium and calcium. And each of those have been looked at in various fashions. And the upshot, I won't go through all those different studies, but one of the most, and the fundamental one has been that of, fruits and vegetables. But the upshot of all these studies have been fairly disappointing because it's been very, very difficult for us to demonstrate any particular micronutrient that is beneficial. Calcium does have some benefit. A higher calcium diet has benefit in terms of prevention of colon cancer. The effect is modest. The issue of fruit and vegetables, which is close to the heart of all gastroenterologists, has been disappointing in this regard because it's been very, very difficult to demonstrate that following a high fiber diet or a diet that's rich in fruit and vegetables will actually prevent colon cancer. We still recommend that. In particular, we recommend that in preference to emphasizing various micronutrients, and the notion being that, that if you emphasize a micronutrient, that hey, gee, you may overlook something that's more important. So now we go for, well, essentially we tell you to do what your mother told you to do, eat fruit and vegetables is what we tell you to do.
That's because, I'm assuming, because we really don't know which micronutrient is doing it, so
Precisely.
you might as well take them all.
Yeah, well, yeah, exactly. And try to eat a diversity of fruit and vegetables, multicolor, adequate servings, and an adequate quantity during the day, 5 to 7 servings a day. Now, on the issue of medications, are there any particular medications that can actually prevent colon cancer? And the answer to the question is yes. There's two categories. One category of medications, they're called non-steroidal anti-inflammatory drugs, and the aspirin in low doses has been demonstrated to actually prevent colon cancer. Now, the effect is small, but it's consistent. But the effect is so small that it's not reliable enough to say, hey, this is sufficient as far as giving you protection. But it is a consistent finding in a number of different studies. The other one has been closely studied is a non-steroidal anti-inflammatory drug called Celebrex. And the other ones in this category, they're called COX-2 inhibitors, have been taken off the market, but Celebrex remains on the market, and it has a benefit as far as preventing polyps from evolving into a cancer and even causing some polyps to regress. And these studies were done most clearly in a special group of individuals that have a high susceptibility to formation of polyps. And it's shown consistently that it can reduce the formation of and the development of cancer from polyps. So that's been exciting, but the trouble is, even here, it's not reliable enough to really say that, hey, this would supersede the need for direct evaluation with the colonoscopy. So yes, indeed, there are medications that have been shown to prevent, but not so reliably that you can rely on these agents. So now there are certain foods that we've identified that actually can promote the development of polyps, and particularly grilled meats of various sort that have been demonstrated promote the development of proliferation of the cells within the colon, and it's believed that is the basis for why there's a higher incidence of polyps and colon cancer in populations who have a high intake of grilled meats of various sort. As far as other kinds of food, animal fats seem to be an issue as well in terms of diets that are high in animal fat. But if you make an effort to eat a diet that's rich in fruit and vegetables, the amount of animal fat sort of correspondingly is diminished, so it becomes less of an issue. So eat your fruit and vegetables, minimize the amount of animal fat in your diet, try to minimize the grilling, and those are take-home messages from a diet standpoint for our individual patients.
Have a steak once in a while.
Yeah, there you go.
Everything in moderation.
Yeah,
right?
there you go. That's
even better.
That's very good.
Well, we'd like to thank you.
We'd like to thank you for coming. And once again, I'm Dr. Greg Leach. This is Jim York and Raymond Phillips, gastroenterologist. We thank you for listening this evening.
All right, thank you. Thanks.